Hi everyone, I'm really glad to have Dr. Rizwan with us today at the Qure booth, and would love to sort of hear more from you in terms of your background, your experience with AI, and as a clinical expert within the domain.
Okay, so thank you. So I'm Rizwan, I'm a consultant radiologist. I've been for 16 years. My interest in AI really stemmed from the usual AI is going to take over the world, AI is going to take over your jobs. And so there was both a professional and personal interest, initially to see how much of this hype and spin was based in reality, how much of it really was a threat to the domain, how much was an opportunity for us in radiology, and I wanted to look at it from that point of view. So what I started to explore after cutting through the whole it will take over the world scenario was how could we leverage it in a useful manner? And that for me translated more into what was my vision of AI. So it was a sort of a personal journey in that, well, if I was looking at the AI space, what kind of things would I think would be good? What would I want to see as a practicing radiologist to support my practice? And part of it then was terminology. You know, let's say lung nodules, for example. You know, I'm a chest radiologist. I've been to many conferences for over a decade, been hearing about CAD, and all of a sudden, exactly the same product was now AI.
Yeah.
Then we looked at the principle of the product, which was fine. How would that support me? How would I make what I was doing better or more efficient or easier? And I found that that was a disconnect, and that was probably the gap which I fell into.
Right. In fact, it's interesting that you say that, because while AI is typically being built out by technologists or engineers, computer scientists, data scientists, the adoption within the healthcare space is in a very clinical context.
Yeah.
So the gap that you talk about as one of the early adopters of AI, how did you go about bridging it? And tell us more about being that clinical champion within the NHS at Bolton.
So that's the thing I found, in that most of the AI products had a very lab-centric view of the world. For many reasons. It can be because they were the data sets that people had access to. It sounded like a great idea, the replication of what a human was doing. And when you looked at how that would translate into something useful for what we were doing, and particularly against the backdrop of, hey, we're going to come and take your jobs, how on earth are you going to deploy something, and how are you going to present the value proposition when it was already coming to an antagonistic market? So what we were trying to do in Bolton was, myself and a couple of my colleagues, we had an interest, and as part of this exploration journey, we were looking at how could we assess a positive impact of AI which was safe for patients, because it was very much, despite all the hype, I use experimental in air quotes. It was an experimental tool. We didn't want to deploy anything, we're a non-academic institution which would have patient impact, because we certainly won't get up for it. And so we were looking at things like peer review, quality assurance, something which would be retrospective analysis and would give us as clinicians some assurance about that.
Yeah.
And it was on this backdrop that we had COVID come and impact on us. And then what I did was I basically took the principles of what I'd just been doing for the past year or two. What would AI mean for me? How would it support? When I say me, I mean the healthcare system, both patients and clinicians. And it was a very sobering position to be sat in front of my workspace, sat in front of the TV, see colleagues die, look at images from around the world, see patients die, see physicians die, and see the healthcare system overwhelmed.
Collapsing overnight.
And that sort of got me thinking, well, generally innovation flourishes in times of need. Wars, that's when you seem to get them for. And here we effectively had a healthcare war. And I started to work up in my own brain. Rather than the products that are being pitched to me, there was loads of, we can diagnose COVID, we can do this, we can do that. Great, I wasn't convinced. And the other way around was, what did I see a potential gap where I thought it could be helpful? And then having worked up my use case, then it was a question of going out to find people who could answer to that, rather than it being the other way around. Because I think up to that point, very much AI was along the face of, hey, we've developed something, now you go away and find a use for it. Whereas what I wanted was, I have a use, you tell me if you can meet it.
Right. In fact, fact, I think that's one of the biggest learnings for AI companies within the healthcare space. Getting AI into clinical practice is very different from having a list of findings or having a technology stack with functionality, and then there's a journey to getting it to a use case, which is relevant, which can have impact. So our work together during the COVID pandemic got quite a lot of national recognition, put Bolton's use of AI on the map, and it's been quite an interesting journey from there till now. What else beyond figuring out the clinical use of AI did you need to look at when you got it into practice at Bolton?
So if I can split up into effectively 4 aspects. So the first one was due diligence, okay, which is what we were doing before the pandemic anyway, what potentially is out there, which companies are publishing, which companies are being open and transparent about the data sets, validation steps, who is being open about regulatory clearance. Then we get into the pandemic, and that's when we had the deployment phase, which, there was the discussions internally. I think I was very fortunate. I work amongst colleagues where we have mutual respect. I have a head of high dependency in ICU, a chest physician who I sat down with him. I sat down with my medical director because we'd already been talking about it in my hospital. We had governance buying, we had medical director buying, the chief technical officer and the chief information officer. We had a team that was ready. So the next phase then was we in principle have got a product, we have a use case that we want to deploy against. Where do we go from here? And then I have a department full of colleagues who are entirely skeptical. And we were deploying basically based on mutual trust. We don't think there's any role for this Rizwan. You think there is elsewhere, go for it. But that's never going to replace me. And that was the important thing, because talking about abstract is one thing. The fact that when we deployed it, people could touch, feel, smell AI, understand the limitations of the product, see that it wasn't a threat for them, and then we could co-create, we could have conversations about how we can use it, how we couldn't. And actually, that's where clinician conversations came in. And if I give you a really simple example, the first feedback I got about the deployment actually had very little to do with the use case we deployed it against, but it was from consultants on the ward which were saying, hey, what we found is our junior doctors are getting much better in their evaluation of AI. Because what they've got is, instead of having to go to teaching, instead of having to go to radiology, pretty much every single chest x-ray they're looking at was then a teaching opportunity, because they have the secondary capture, they had the AI output for it. And that's the principle, I think, which I would suggest, which is don't be so regimented in what you're doing with the product. Even when you deploy it, you're always going to encounter unexpected positive and negative things. And if I give you, I'll balance the positive with the negative, which again is about junior doctors. I thought we had it all. Our comms was great. We had a patient poster. We had buy-in from all the senior important people, and all of a sudden we had a deluge of complaints saying, "Why are all your X-rays looking different?" And who did we forget to involve in the conversation? The junior doctors. The bulk of the workforce who were actually providing care were suddenly seeing something new, and we didn't explain to them what it was there for and what we were doing with it. These are learning experiences which we should never take as a threat. You grow. We figured out appropriate comms, brought them into the conversation as well.
In fact, credit due to Bolton, you did not just implement it at your own trust level, you also disseminated and shared that learning and knowledge as an early adopter across NHS, and that itself has quite a lot of value when a new innovative solution is coming into the system. And then the situation changed again. Thankfully, COVID is a thing of the past now. And how did that sort of evolve from the use case you originally intended to put it in? And then what did you sort of look at in terms of a longer term plan and scale potential?
So exactly the first thing you said. Bolton isn't a teaching hospital, it's not an academic institution. And up until that point, AI was a toy for the rich and famous, okay? It was deployed in highfalutin environments. And all of a sudden we had a small district general hospital in the northwest of England who were using it for a specific purpose. And that was the part which was important to me, because we were also open about the things we thought we did well and the things that we want to support from. And I suddenly realized that, hang on, I was fortunate in that, I get to speak to people like you, I get to speak to Don Cushion, and because I knew them because there's a shared interest. Whereas people who weren't invested in AI, who do they talk to? And that allowed us the conversation to say what we need to set up across the country is a forum where people who may be interested but are hesitant, don't know where to, why would a clinician want to understand regulatory clearance? It's not something we want to do. We're not data scientists. Why on earth? Every undercurve still breaks me out into a sweat. That's the thing. And so that's where, the AI playbook, in interested parties got together. These are the kind of questions you should ask for. These are the kind of things to look out for. And it allows an informal evaluation of the products first. And then once you've got them in place, you can then start having the conversations with your partner, and that in itself I think is very important. Far too much focus I think was based on the algorithm. The algorithm is important. All the metrics we've talked about, all the AUCs, all the regulatory clearance, all that is important. At an early stage, if you're going to co-create, you need to have confidence that the company that you're talking to considers you more than a cash cow and considers more than a flag in a hospital. And I think that's where we were very fortunate. I felt open to be able to have conversations with Qure. We talked about what kind of things we might want to do, what was already in the products that you hadn't thought about, I hadn't thought about, how we can make it useful, or what we might want to do together going forward.
In fact, very rightly said, and that's been one of our biggest learnings from the Bolton experience. There was a really intense learning curve where we were getting to learn from the shop floor or from the hospital ecosystem itself how AI will behave in clinical practice, and that was invaluable to actually go back and tailor our products or package that in a way where it would be having the maximum value for clinicians and take care of all of that checklist of their concerns with regards to patient safety, data transfer, and all of the lovely things.
So that I guess takes me to my third part of my 4-part plan, which is we've done due diligence, we've done deployment, then it's the evaluation aspect. And so in terms of a practical aspect, what we did was we split our team into 2, which were effectively kept separate from each other. Because I was involved in the initial implementation phase, it wasn't proper that I was involved in evaluation. So we spun up another team for another colleague who had an interest in AI, and she managed the evaluation side. Of course, we met regularly and we touched base, but there was never any part of the implementation team who had any part of evaluation because we wanted to keep that pure. It was pointless to feed anything back when there was any suspicion, real or perceived, that there was any compromise to that. And what it also allowed us to do was to have the conversations with the academic health centre. We had, we wrote up a digital case study for NHS Wales and NHS Digital. We talked about how we could find appropriate funding for that. And so the evaluation isn't the formal metrics that people talk about, but there was also a softer clinical evaluation piece, which then started us on the journey of where do we go from here? Where do I then have to sit in front of my director of finance? What are the kind of things that we need to look at which would justify the value proposition for AI?
I do want to touch on the last point with you. There was, of course, a lot of awards and accolades that Bolton won. Gartner did a case study on the Bolton deployment of or use of AI during the COVID and the impact it had. You also leveraged it fairly well in terms of scaling up within the region. Tell us a bit more about that.
So there you nicely segued into part 4 of my 4-part plan. And so due diligence, deployment, evaluation, scale. And so that was having then used something, having been open to sharing our experience so that internally and with colleagues, we then had, in the first instance, trust around us who were saying, we're interested in the space, let's at least, how would we figure this out together? We were open sharing. It was important for me to try and see what we could do together. So first it was, what projects could we spin up? 2 aspects. One is either replicate what we're doing at individual trust, which was just one form of propagation, but the next phase was work collaboratively to see what we can do, not at an individual patient level, but at a system-wide level. And that's where the scale happens. So that's when we started talking more about the value of, for example, nodule detection, early detection of lung cancer on chest x-rays. And to do that meaningfully, that can't be done in one institution. And so we've started a pilot in Greater Manchester to do that at scale as well.
Definitely. In fact, the project is going live across multiple sites now. It's a really interesting blueprint for potentially what AI across the region can look like, and hopefully we can collect here again at the next RSNA and share some of the broader learnings across clinical, operational as well as cost benefit value of AI for health system across the region.
That'd be fun. I think all I'd say is more broadly, what we've learned from this is collaboration and communication is key. AI companies, I think, are starting to understand clinical input is important to help create it. Clinicians and the healthcare system is starting to understand it is not a threat, and actually there are valuable aspects that we can use these tools for to improve the care we provide both for patients and also the care we provide to improve efficiency in what we're doing as well.
Perfect. Thank you so much, Dr. Rizwan, for being an early adopter of
My
AI
pleasure.
and a clinical champion, and we look
Thank you.
forward to hearing more.